cancer. Prof. Ruzanna, the floor for you. You can share your slide. Thank you so much and appreciated your time today.
Thank you very much, Dr. Imad, for a kind introduction, and also the South Africa and the whole team for inviting me to give it for today. So, our talk for today, as it was mentioned, is dedicated to the approach to a new case of mediastinal mass, and today we'll discuss all details, starting from diagnosis and ending up with the management. So, of course, we will talk about understanding the anatomical compartments. We will learn about common causes of the masses, review the diagnostic tools and biopsy techniques, discuss the management, and also recognize the emergencies as special considerations in case of mediastinal masses. So first of all, mediastinal masses are rare. It can be, of course, life-threatening. So it's very important to recognize the symptoms and the emergency situations as soon as possible. It's compromised from 1 to 3% of chest tumors, and usually and in most of cases it's discovered incidentally. So let's start with I would say like a very short case intro, and then we will discuss the whole details. So all emergency situations usually start at the Friday night. So it was a Friday night, and 14-year-old child was admitted to our hospital with dry cough, nausea, fever, and weight loss. So initially, from the very beginning, X-ray was done and also a CT later on, which showed, as you can see here, a bulky mediastinal mass, and the volume was approximately more than 600 milliliters. And you can see here that it's compressing the adjacent major vessels and organs. We will stop here and discuss the anatomy of the mediastinum, because to understand the symptoms, the reasons, etc., it's very important to understand the anatomy. So this compartment, this mediastinum, it runs the length of the thoracic cavity, here we can see, and between the pleural sacs of the lungs, and it has no physical barriers other than pericardium, and it extends longitudinally, as you can see here, from the thoracic inlet to the superior part of the diaphragm. So another pictures about this. So theoretically, it is divided into superior and inferior, and the inferior mediastinum, in that case, is subdivided into anterior, middle, and posterior parts. And here we will discuss, of course, this now. And please, if you will have any questions in the middle, we can discuss that, or we can discuss later on, or you can put it in the chat. So about the compartments and what is located in each compartment. So we do have here in anterior mediastinum the thymus, fat, and lymph nodes. So hence, here we can see mostly germ cell tumors, lymphomas, thymomas, etc., etc. In the middle mediastinum, we have the heart, pericardium, we have aortas, veins. So here we can see aneurysma, cyst, and to be honest here, we very rarely see any neoplasia. So mostly in this case, if it's middle mediastinum, we see aneurysm, cysts, hernias. And then we have the posterior mediastinum, which where we do have esophagus, veins, aortas, nerves, and lymph nodes. So usually what we do have here and which diseases we are dealing with are aneurysms, are lymphomas, are meningoceles, and neurogenic masses. Another subdivisions and the most often tumors, neoplasias that we see, it's divided, as you see, benign and malignant, based on the compartments that we had. There are many mnemonics to remember the mediastinal masses. One of them is vitamins. So it can be vascular, as I have discussed. It's aneurysm, hemangiomas. It can be infectious or inflammatory. It can be traumatic, autoimmune. M stands for metabolic. I stands for iatrogenic. Then, of course, we have this huge group of N, which stands for neoplastic, and then structural. Another mnemonic, this is for anterior mediastinal masses, is the 4 T's. So we have thymoma, we have teratoma, thyroid tumor, and terrible lymphoma. Let's call it like this. So we understood what is located where and what we should expect, but how to approach the patients with mediastinal mass. So as in every situation that we have in children and adults, we always start with history and physical examination. Then we have imaging studies, lab studies, and tissue diagnosis. So let's start with the anamnestic and complaints. It can be asymptomatic and symptomatic. So about asymptomatic, we usually, as I mentioned before, it is usually discovered incidentally. But of course, we might have symptoms also when when the masses often presents due to compression or invasion of adjacent structures. It can be vessels, it can be organs, esophagus, etc., etc. So common symptoms, of course, it's connected with the structure that is compressing. For instance, chest, it can be chest pain, and related to compression or invasion, it can be cough, dyspnea, and of course, this is the compression of trachea or bronchus. It can be Horn syndrome. Probably you have heard about this, which include ptosis, meiosis, and anhidrosis. And usually we see this in posterior mediastinal masses. Sometimes patients can come with dysphagia, which is difficulty of swallowing due to esophageal compression, and hoarseness whenever we have the involvement of recurrent pharyngeal nerve. So about common symptoms of mediastinal mass, so there can be life-threatening signs. So the most important things are superior mediastinal syndrome, which includes orthopnea, hoarseness, stridor. It can be superior vena cava syndrome, and here we can have the fascial swelling, venous distensions. It can be airway compression, again, stridor, respiratory distress, and spinal cord compression, which can be mostly neuroblastomas in small children. And the symptoms of it can be limb weakness and paralysis. So it's important to say that in all these scenarios, life scenarios, it's very important to act as quick, as fast as possible. So superior mediastinal syndrome, it occurs due to compression of trachea and great vessels, and usually it's we're dealing with superior mediastinum, and the reasons of having this syndrome can be malignant and benign. So whenever we're talking about malignant, and I should say that in most of cases it's malignant, it can be lymphoma, germ cell tumors, and thymoma, and rarely we see the causes as infection or fibrosis. So here we have a mass effect and compression of trachea, esophagus, superior vena cava. And all these can rapidly progress to airway obstruction and cardiovascular collapse. So let's like subdivide the superior vena cava syndrome versus superior mediastinal syndrome. I have to say that superior vena cava syndrome results in CMS, and these two terms are often used interchangeably, especially in children. So malignant obstruction can be caused by either direct invasion of tumor, either external compression, or both external compression and thrombosis can coexist. And the clinical feature of this syndrome is a swelling, chest pain, respiratory symptoms, and neurological manifestation. And sometimes, of course, patient can come with headaches, confusions, and due to cerebral edema, visual or auditory disturbances. And I have to say again and remind you all that this is life-threatening situation. So in these cases, we should act as fast as possible. Of course, there are some management algorithms. I won't go deep into details to all these, but as here you see, whenever we have any suspicion of this syndrome, we should like immediately obtain the imaging studies and understand whether if there is a life-threatening symptoms, the first and the most important thing is to stabilize the patient. And later on, do all these things and understand whether what is the reason of having these syndromes and solving that problem initially. Now, we have talked about complaints and anamnesis. Now it's turn for imaging studies. So in every case, especially in LMICs in resource limiting settings, we always start with X-ray, especially when we are like treating the patients in the places where like MRI or CT won't be viable at that case. So X-ray, what are the advantages of this? So it's very quick, it's widely available, it's very cheap, and is very useful to detect the mass, to understand whether there is a mass or not. And it's a standard of care to measure the bulk of the disease. However, it has low sensitivity and specificity, cannot differentiate wherever, I mean, the tumor is coming. We cannot like easily understand whether it's posterior or anterior. We cannot understand, of course, via X-ray whether it's solid or cystic mass. And of course, the problem is between the mass type. And of course, the problem is with anatomical information. So, and here we see that the mediastinal bulk on the X-ray, we can understand here using these formulas and measure the bulk of the disease. So next step is the CT. Which advantage? It's again, it is widely available in many LMICs. So it's high resolution imaging for mediastinal structures. It helps to differentiate whether this is cystic, vascular, or solid mass. This helps to assess the mass effect, and this is very important whenever we are planning to do a biopsy. Disadvantages, again, it's radiation exposure. We should remember this. It requires contrast, and in some cases, especially when there are some kidney problems or some allergic reaction, you cannot use the contrast. And if a tumor is arising from paraganglia region, for instance, in case of neuroblastomas, I have to say that its visibility would be a bit limited, and in some cases, MRI will be required. And this is like a CT, what we see using the CT of the patient for with the non-Hodgkin lymphoma. And here we see the superior vena cava is occluded and kept open by portacat. These are this row here. And the left lateral thoracic veins are dilated and enhancing. And here we see all this lesion here, and CT help us a lot in helping us a lot in terms of understanding the nature of this issue. So there is definition using EuroNet protocol. This is for lymphomas. And what is the definition of having the bulky disease, and what does this mean? So bulk presents if the volume is in the largest contiguous lymph nodes, mass is more than 200 milliliters. And in the mediastinum, the total volume of the initial tumor mass in the upper, middle, and lower mediastinum and both hilly and both supradiaphragmatic is considered contiguous for bulk assessment due to complex anatomic structures. So here there is another calculation for this, and we are using this for lymphomas to understand whether we are dealing with a bulky disease or not. So why it's important to understand whether it's bulky disease or not, because the whole treatment and the staging is based on that. And here you see how it's measured. So we have the three sizes. This is the A, B, and the C longitudinal size. And if it's more than 200, it's considered as a bulky disease. So we have talked about CT, and now it's turn for MRI. So it's very important technique for vascular involvement for neurogenic tumors, as I mentioned before, especially for neuroblastoma, and it has no radiation. However, it's expensive, and I have to say in many LMICs, and not only in LMICs, it's very difficult to obtain these tests. It's longer scan time, and especially if you're dealing with life-threatening situation, with emergency situation, your choice will favor to CT rather than MRI. And in case of MRI, we have a poor resolution for pulmonary parenchyma. So whenever you have the emergency situation, it would be better, of course, to do initially, of course, X-ray than CT. And here are some couple of images of mediastinal mass and how you will see in the MRI. As you see here, the lungs are very poorly resoluted and it's very difficult to understand, but it's very important, especially for pharyngeal lesions. So now it's turned for PET-CT. We are doing the PET-CT whenever we already know the diagnosis. We're not doing the PET-CT to understand the nature of the mass. And in most of cases, we're obtaining PET-CT for the staging of the disease. So PET-CT determines the site of involvement by detecting the metabolically active lesions, and I will show in the next slide. And we are using, of course, PET-CT to evaluate the response to therapy. This is especially important for lymphomas, for neuroblastomas. This is so, just to remember, this is important for the staging of the malignancies and how to detect and understand whether there are any distant metastases or not. The disadvantages, of course, is the high costs, limited viability, and in some cases, there might be a false positive answers, especially when we are dealing with inflammatory or infection conditions. And here we do have the PET-CT and the staging for, this is for lymphomas. It's called the staging system called Ann Arbor. Probably you have heard about this. And these are the examples. This is stage 1, whenever only one lymph node compartment is included, or single extra lymphatic site. Stage 2, 3, and 4, and here you can see whether you see the involvement of different bones and other lymph nodes everywhere, and there are like multiple lymph node regions in both sides of the diaphragm. So next step, we have talked about imaging studies, and now the next step is our invasive procedures and talking about the diagnosis. So there are a couple of invasive procedures that we sometimes obtain in case of mediastinal mass. So we need to have the biopsy, because just based on CT or MRI, it would be difficult to understand the nature. However, I have to say that before starting any invasive procedure, we should remember that the first thing is to stabilize patient, then do any invasive procedure. And in some cases, even in the protocol of neuroblastomas or lymphomas, they sometimes suggest to start treatment, like for instance with steroids or chemotherapy low dose, stabilize the patient, and then obtain biopsy. But of course, we will talk about this. So surgical procedure to what is the mediastinoscopy? So this is a surgical procedure to visualize and biopsy mediastinal lymph nodes, and it's very useful for the staging lung cancer and diagnosing the lymphoma. Here you see how it's done. The mediastinoscope, the incision is here, and it's performed through a small incision in the neck, as is shown here. Another invasive procedures are bronchoscopies with EBUS, and I have to say that in many LMICs, these procedures are not viable. This allows to visualization the airway and sampling the mediastinal lymph nodes here, this way, and and endobronchial ultrasound is used. It's less invasive than mediastinoscopy because it's without any incision or something. And real-time ultrasound guidance, we have the access of that for the needle aspiration. Another surgical procedures are video-assisted thoracoscopic surgery. Again, this is minimally invasive surgical approach, but this is very expensive and it's not viable in many LMICs. So this is smaller incision, less pain, shorter recovery time compared to open surgery. And of course, in many cases, whenever this mediastinoscopy or this VAT is not viable, open biopsy is done. I mean, whenever other methods are not visible or it's not possible to do. So this has a larger incision, of course, and longer recovery time. So, of course, there are some other lab tests that we are doing apart from the biopsy, and this might help you, especially when the patient is not stable and you have to think and you have to start the treatment as soon as possible. We always check for lab studies. So what you can check? So you can check for AFP. So this is especially important for germ cell tumors. And for instance, if the patient is not stable and you have very high AFP, so you can stabilize patient, you can start some chemo and then obtain the biopsy. So this is very specific and sensitive. And so as you see, we can do this. This is not so invasive as the biopsy, and the same is for beta foreign gonadotropin. This is important, especially for non-seminomas, and I mean these two are important for germ cell tumors, so it will be easier to detect them. So LDH is not specific, I have to say, compared to AFP and beta gonadotropin, and may be elevated in patients with lymphoma, but I have to say this is not so specific or sensitive marker to detect. Then we have the NSN, neurospecific analyzer for neuroblastoma. This is especially important for the children under 5-year-old. And in children, again, if they're small children and we suspect neuroblastoma, we always check for VMA and HbA in the urine. And this is very sensitive, like up to 90% sensitive and specific for neuroblastoma. So these are the lab tests that you can also do, and this might be very helpful for the diagnosis. So about the tissue diagnosis, as I said, you have always balanced the need for diagnosis with patient safety. So biopsy of the mass is needed to confirm a suspected diagnosis. However, you can, in some cases, you can, not all cases, you can start with the treatment and do the biopsy, especially if the patient is not stable. So we have to avoid any tissue diagnosis, any biopsy, especially if we have the severe airway compression. So if you do biopsy, you have a risk of complete obstruction. We should avoid doing biopsy if we have a cardiac tamponade and if we have a huge mass effect on the major vessels, because there will be a risk of bleeding or collapse. So at this point, let's return to the case that we have started initially. So a 14-year-old child with dry cough, nausea, fever, and weight loss. Here we have this huge mass, And what we did by that time, the biopsy, since the child was stable, the biopsy was done and it confirmed the diagnosis of Hodgkin lymphoma. And in case of Hodgkin lymphoma, of course, I won't go deep into details on this EuroNet protocol, but we do have the risk stratification. We do have the staging system and treatment group. And this is very important to allocate to the correct group to understand what should be our treatment approaches for these cases. And as you see, it's very important to understand whether there is a bulky disease or not. So this is a risk factor, and as you see, and very important to understand from the beginning. So what is the management of mediastinal masses, and especially when we are talking about lymphomas? So the final diagnosis of this patient was Hodgkin lymphoma, as I said, nodule sclerosis type, the most common type. And the patient had B symptoms. What this means, whenever the patient has a fever, night sweats, and weight loss, these are considered B symptoms. So, and as you see here, B symptoms are also important for the staging, and we are writing the staging, and then we are writing the next to it B. So main treatment of Hodgkin lymphoma include chemotherapy plus minus radiotherapy. And I have to say that the treatment of Hodgkin lymphoma now and treatment of Hodgkin lymphoma, like for instance, 10 years ago, is different because this is the disease that has very high survival. And this is the disease whenever we are dealing with late effect complications. So it's very important to do the correct treatment. And current protocols are, in most of cases, are avoiding radiotherapy. So it's very important to understand the response. And if the PET-CT is positive after 2 cycles of chemotherapy, then the patient usually receives the Degobax scan, not just regular Copdex. So I have to say here, and what we do have to remember here, that PET-CT is important for understanding the response to the treatment and later discussing and deciding the further treatment of the patient. Then we do have another case, and we do have a case number 2. Whenever the patient came to us with a general weakness, and I'm showing here the real patient from our department. Whenever the patient came to us with general weakness, abdominal pain, and fever, and dyspnea, we did a CT, and it showed the tumor located in the left mediastinal part. And as you see, in this case, in the case of 10-year-old girl, this lesion was up to 8 centimeters, as you see here. And as you see here, this is the CT of the patient, and here this is the huge mass in the mediastinum, and you can see how big it is. So what was done so far? Again, luckily the patient was stable at this point, and fine needle biopsy was done and confirmed the diagnosis of synovial sarcoma. So as I mentioned before, we can deal and we can have the scenario whenever we'll have the sarcomas. And usually in this sarcoma, SS18 translocation is very important for confirming the diagnosis. And this is the roadmap. This is from the protocol of the management of sarcomas. And here, as you see, it's very intense treatment, and it's most of cases include surgery, chemotherapy, and radiotherapy, as you see here. In most of cases, so I have to say that surgery and radiotherapy are very important things and very important parts of the treatment. And here as well. Based on the arms and based on the risk groups, we have different treatment approaches. And of course, in this case, this is the after treatment approach, and we had a very good response to chemotherapy in this child. And luckily the lesion, it was possible to completely resect the tumor, and later on the child received additional radiotherapy, and the child is currently on follow-up and doing really great. So another case again, the symptoms basically are nearly the same. So this is based on the location. So despite the fact whether it's sarcoma or lymphoma, of course there might be some differences in terms of complaints, but in most of cases it's the same. So again, this is the case number 3. And the patient came to us, this child was small and came to us with fever and dyspnea. So MRI was done and CT also. And MRI showed the pathological lesion in the bones, including the pelvis, femur, and vertebra. And what about the CT? It showed the right mediastinal mass, which was measuring up to 9.4 centimeters. And here, this is the tumor again. And based on just CT or MRI, it's very difficult to understand the nature of the tumor. This is another one. So this child is 7-year-old, and here you can see this lesion here. So the diagnosis. So the biopsy was done, and the diagnosis was neuroblastoma. Another very common, and I have to say that neuroblastoma is the most common solid extracranial tumor. And especially this kind of tumor is the most common is in children from 1 to 5 year old. And in this case, very important to understand all the molecular, all the molecular genetic testings, because in case of neuroblastoma, and I will show it here, it's very important to understand the stage, and we will talk about this in the next slide. So in case of neuroblastoma, it's important to do not only the CT or MRI, but also to obtain an IMG scan or PET-CT to understand whether there are distant metastases or not. It's important to do bone marrow aspiration and biopsy. And neuroblastomas are staged based on the recent International Neuroblastoma Risk Group staging system. Yeah, and here you can see this is from Irving paper, an excellent paper, I have to say. And as you see here, the staging is different in different types of tumor. And in case of neuroblastoma, in this kind of tumor, we should understand that the age of the child is the most important thing. What does mean L1 or L2? L1 means that the tumor can be resected initially, and L2 means that the tumor cannot be resected. And there are image-defined risk factors. So again, as you see, the age of the child is the most important thing for understanding the risk group. And based on the risk group, we are deciding the further treatment. M is metastatic and MS is for the small children. So yeah, and I have discussed this already about the staging. And as I said, in case of a low-risk neuroblastoma, if the child is small, we can always discuss the watch and wait or observation. Surgery in some cases is done. And in case of unresectable disease, chemo can be considered, and radiotherapy in case of emergency situations. But as you see here, in intermediate or high-risk group, there is no watch and wait strategy. And it's especially in high-risk neuroblastoma, the treatment is really very intense and includes chemo, surgery, transplantation, radiotherapy, and immunotherapy. So we have came to the summary, and we should remember the following. So safety is the first, diagnosis is the second, and management is the third. So the most important thing is the priority of the patient is the patient safety. And we have to remember to secure airway if needed, to stabilize the patient if needed, and don't rush to treat based on only imaging, And we should remember that the safety, again, safety and safety all the time, especially when we are dealing with mediastinal masses. Yeah, and we have approached to our last slide. Okay, now I'm here and listening to your comments and questions about this important topic. Let's see.
Thank you so much, Ruzanna, for your presentation and kind time with us. I have few questions actually from my side. It's always like a mediastinum mass nightmare, especially when you presented with life-threatening condition at mid of night when the residents call you regarding that. But I have one question. We always in Africa, we low resources and limited tools, and it's difficult sometimes to have skillful people to do biopsy without major issue or harm the patient. My question regarding if the child is presented with life-threatening condition, we don't have option to do biopsy, and we don't have open window lymph node, for example, or tissue. Which kind of chemotherapy combination we can use it until stabilize the child before we access for biopsy tissue? Just we
Thank you for this
Yeah, my
important
question.
question. Yep. So I'll
Mhm,
start with answering with this question. So this is very important because we have faced with a similar situation many times, and usually this kind of life-threatening situation happen in the Friday night, whenever you do not have
mhm,
like, I mean, in my hospital as well, sometimes you do not have like surgeon there, or you have to
mhm,
refer the child to a hospital which is far from your hospital, own hospital. And I do completely understand the situation. So based on the protocol, again, we usually discuss what it can be. So based on the age, for instance, if the child is small, like less than 5-year-old child, you think or have like any cord compression symptoms, you sometimes think about the neuroblastoma or
mhm,
lymphomas. And in this case, usually it's something that grows rapidly whenever the child has all the symptoms. And we often think, and in the protocol of Euronet, it's very clearly written that do not obtain biopsy if the child has an emergency situation. Usually, it's recommended to start with steroids, of course, starting with the lower dose. Because if you start with the higher dose, you will have a tumor lysis syndrome and you had to deal with another emergency situation. So start with a low dose steroids, and there is also one chemotherapy medication that will work in most of cases, and it's cyclophosphamide. And in the
mhm,
protocol, it's written again low dose cyclophosphamide and steroids. So why these two medications? Because these two medications help in most of cases. If it's lymphoma, it will work. If it's neuroblastoma, again, it will work. If it's sarcoma, again, it will work. If it's germ cell tumor, again, it will work. So that's why it's considered the combination of two these medications. And this is the thing that we sometimes do whenever we cannot wait. And I have to say that doing only 2 or 3 days with this medication and stabilizing the patient, you won't have problems with the biopsy material. I mean, the tumor won't vanish in 1 or 2 days, but you will have the time, you will stabilize the patient, and then you can obtain
mhm.
the biopsy. And we had a couple of cases like that whenever we had to start the treatment before the biopsy.
Yeah, thank you so much. You answered my second question regarding the role of steroid in
Yeah.
mediastinum mass. Yeah, but my question regarding the dose of steroid, prednisolone, and the dose of cyclophosphamide. What's the lower dose you can use?
So it depends, to be honest. It depends on the availability or which kind of medication you currently have. So if it's prednisolone, dexamethasone, there are different protocol in this, but it's clearly written in the
Mhm.
urinary protocol, and I can share with the groups that part so you can use that. So it depends the availability at your hospital. But
Okay,
I would
thank you
say
so much.
even in the protocols written the X dose, like for DEXA or other things, you can start with the lower dose, see how the
Mm,
patients react, and and of course it depends, of course, the lab test. I mean the CBC. If we have very high leukocytes, you have to be very cautious because what if it's
okay.
like leukemization, and what if you have a not only mediastinal mass but also the bone marrow involvement. So I would do in these cases the CBC, complete blood count, and depending on leukocytes level, I will decide the dose of the steroids. I mean, not to do the higher
Mhm.
dose and to have other emergency situation.
Yeah, as you mentioned, it's not one part. You have to take it completely regarding the history, the age of the child, the site of mediastinum mass, and the characteristic of the mass. Just this is what type of tumor, then and biochemically, if suggested lymphoma or leukemia, then you treat it according for that. Okay, we have two questions regarding one question from participant. Would the radiotherapy be option if the cyclophosphamide and steroid not available?
In some cases, yes, you can do radiotherapy, but I would say that, cyclophosphamide steroids would work faster than radiotherapy
Mhm,
because let's think, I mean, if you do not have access to surgeon, will you have access to
mhm,
radiotherapy department? Because like probably it's only my centers thing, but I mean, we do not have radiotherapy department at our hospital. So we have to
mhm,
send them first. And the second, for obtaining the radiotherapy, you have to do CT and you have to do, or it takes some time, right? For like measuring the tissue mass and doing the radiotherapy. I mean, for techniques, you need physics, you need radiotherapy specialists. So I don't think that it's possible to do this. This cannot be like in an emergency situation. So if it's Friday night, you won't do that. If it's Friday night, you will do
mhm.
steroids and cyclophosphamide. So it depends,
Yeah, yeah,
about this.
and it difficult and which the dose you will use it and expose the lung and the heart for radiotherapy, and you don't
Oh,
know the tissue biopsy. This is difficult decision, I think so.
this is for me, yeah, difficult because I'm not radiation therapist, but I have to say that again, usually in most of protocols, it's low dose radiotherapy.
I used emergency radiotherapy once in my time in wing sarcoma. He came with spinal cord compression, and that was acutely, but and it was big boy. It's not a smaller one. It was 12 years old, and he has also another side of tumor. It was metastatic, looks like, because he has complaining from the right foot pain, and he has osteolytic lesion in the right foot pain. I use it once, as emergency situation. I haven't used it before radiotherapy as emergency. Okay. There is one question regarding the role of PT scan and mediastinum mass management, especially in expensive situation in lower income country. You have to do PET scan for every patient with mediastinum mass.
No.
As I'm
Uh,
understanding my question.
yeah. Yeah. So we will want to do PET-CT in all masses, but it's crucial. Let's start with the crucial thing. It's crucial for Hodgkin lymphoma. Because for Hodgkin lymphoma, you decide your further treatment based on that capacity after the second round of chemo. However, I have to say that capacity is not viable in many countries, and I have to say that even in Armenia, it became a viable just
Mhm.
let's say recently. And before that, we were either sending to abroad, but sometimes patients do not have that, and we were doing the CT. But PET-CT is more important because it showed the activity of that lesion. Whereas sometimes CT can show the sizes, but it cannot show whether there is a vital tumor there or not. So we'll do definitely for Hodgkin lymphoma. We would do for neuroblastomas to understand this whether there are distant metastases or not. And of course, especially for Ewing sarcoma, it's very important. Like for instance, for synovial sarcoma, for osteosarcoma, but this is very rare to have like mediastinal inclusion, is like I would say less crucial, let's say,
Mm.
but it's crucial for Hodgkin lymphoma, for neuroblastoma, for Ewing sarcoma.
It
So
means it's important for after the tissue biopsy to staging
yeah,
and
usually we
further
do that.
development.
Yeah, it's important for the staging, not for understanding the diagnosis, but only in lymphomas or for Hodgkin lymphoma, it's important for the further management. For non-Hodgkin lymphomas, which can also be as a mediastinal mass, it does not have so many crucial things, and we do not do that for non-Hodgkin lymphoma. So there is based on the subtype, let's say.
Okay. And there's another question regarding the lower dose of steroid and cyclophosphamide. You mentioned that for the
Yeah, we already talked about that.
yes, yeah. Thank you so much, Prof, for today. It was great presentation and great review regarding mediastinum mass. I know it's nightmare, but we have to deal with it usually. Okay, thank you so much for your time. I appreciated your time. Thank you so much.
Thank you so much for the invitation, and we
Oh,
really hope that this was helpful.
sure, sure.
Thank you. Have a great day so far.
You too. Thank you. Have a nice night. Thank you so much.